Welcome, everybody. I would love to know where you're coming from if you want to use the chat box. We're coming to you live from Clearwater Beach, Florida. Very, very excited for you to be here today. Let's see the chat box. Thank you, North Carolina. Thank you so much, Medina. Ooh, Orlando. We have Ohio. We've got Boston. Oh, Erica. Hi, Erica. So excited that you're here today. Washington State. Oh, hi, John from Austin, Texas. Thank you so much for the recent follows. We really, really appreciate that. Birmingham, Alabama, Iowa. Hi, Anna and Dr. Aziz. Hello. Thank you guys so much for being here. So I think that we're ready to start. And just wanted to introduce myself. My name is Anna Rosnowski. I'm the Chief Operating Officer of CDIQ Consulting. Welcome to today's free Lunch and Learn webinar for November 2025. Today's topic is social determinants in healthcare in CDI workflows. We really appreciate you all being here today as the best part of our growing CDIQ, CDI community. Now I'm honored to introduce our founder and CEO, Dr. Tarman Aziz, MD, CCDS. Dr. Aziz is a HIM executive, founder and CEO, internal medicine physician with over 13 years of CDI experience. What can we share? Dr. Aziz, please share with us what we've been up to this year.
Thank you so much, Anna. Yes, and welcome to everybody. It has been a busy 2025 for us. We're thrilled to have been involved with so many different activities. Just a few of the highlights here. Back in February of this year, we did deliver a topic of acute tubular necrosis to the virtual coding summit sponsored by AHIMA in February 2025, and that was really interesting. We were asked to write a journal article in the Journal of AHIMA afterwards, and still fielding wonderful correspondence around the topic of ATN and how it presents unique challenges to the workspace. So good that is still such a interesting area of collaboration and focus. We have been supporting a number of individual hospital and state level ACTIS education chapter meetings, and as well as the national level AHIMA 25 conference in October. That was our big excitement for last month. Just a blast to be at that and deliver our pre-conference workshop and enhancing CDI outcomes, best practices in documentation and coding. And in fact, next month, our Lunch and Learn free webinar will be a case study taken from this very same hospital where the cases we presented in that workshop were derived from. So some lessons learned from some program optimization that we did at a facility recently. Most recently, last week, was in attendance at the American Case Management Association's Leadership and Physician Advisor Conference, which was another great opportunity to speak and interact regarding our way of educating on CDI, particularly interested in our work on physician advisor and documentation champion education and training in this particular session. And it gave us a chance, because that conference highlights utilization review and case management and others, intersection points with CDI and coding. We were in attendance with Bulwark Health, who we're happy to announce is our latest channel partner. They're our preferred software vendor, and they offer a very comprehensive software solution that cuts across all sorts of needs, A to Z needs, from the decision to admit to inpatient status all the way through to discharge and post-discharge planning. So we're busy, we're excited, and we're thrilled that you're here. Let's get into the topic of the moment. And we're going to start out with a question right away before we dive into the concepts and some introductory commentary. I'd love for you to use the chat box or to take the microphone if you feel comfortable to do so. And come on and let us know what you think about question number one here. Some of you who read quickly have already read the question and the choices. If you don't mind, somebody come on and let us know what you think the best answer is.
C.
I see a lot of choice C being selected. Thank you. Is that you, Medina? Please feel
Yes.
free to share. You're correct in your response.
Yes. I would code for the unstable work hours, all of that, because that lends into her financial issues, of course, the food issues.
That's right. Yeah, we have a lot more going on than one single social determinant of health in this instance, correct?
Yes.
And so if you were not already familiar, the notion is there's no limit on the codes as long as they're not redundant or inaccurate. You'd want to use as many Z codes for those determinants as would be appropriate. You wouldn't want to leave any of them out. So assign for each and every situation. Let's take a brief aside from the question and presentation format to just consider something about these codes. So first of all, before we get into any more sharing of the screen, how many of you are familiar with some of the updates that have occurred with fiscal year 2026 ICD-10 CM coding, and particularly how it pertains to the Z55 to Z65 family of codes? Where were those changes made? So there are some that are CCs. They've been CCs for a while. And we have some interesting ways of applying that CC capture. So that's correct. What else does anybody want to share about Z55 through Z65? This is, if you're in CDI, this is an area of the code set that many CDI specialists sort of glaze over when asked about them, as well as the Y codes for that matter, because a lot of the time we see them as codes that the coders, the inpatient coding team, might be interested in picking up every small detail, whereas we're very sharply focused on CCs, MCCs, HCCs, other chronic conditions that affect risk adjustment and so forth, quality measures, POA status. But every place of occurrence and social circumstance may not be front and center. And as Medina correctly shares by chat, some of these are impactful to SOI, ROM. They may be the only CC on the record, therefore having a potential fiscal impact as well, depending on the patient's presentation and circumstances. So it would definitely benefit every CDI specialist to think about the Z codes and think about how they might pertain to both fiscal and quality outcomes. Now, I don't know how you all organize your codes, but in general, I keep mine on spreadsheets. So the Z codes are all listed here, starting with Z55 there at the top, and go all the way through to where I've drawn another yellow line through. So we can see many different categories. We'll talk about them in a moment. We do see a few that light up as CC diagnoses, which of course in CDI, we're always eager to know when a secondary diagnosis is a complication, comorbidity that potentially impacts the record in some way. So we see these related to housing, homelessness, stability of housing, and so forth. We also see here, I've got a red line through one of these for fiscal year 2026. Z5986 has been retired and replaced by the three that you see beneath it. So financial insecurity, no longer valid in and of itself as coded before. We now have 861, 8, and 9, very specifically for financial insecurity with difficulty paying for utilities, very specifically for that first code. And then other specified financial insecurity. If you dig into the description a little further, here we're talking about bankruptcy, debt that exceeds the capacity to be paid back, sudden deficit in income that was unanticipated, leaving a person in that global situation of financial insecurity, and then sometimes the insecurity is unspecified, depending on the nature of the admission and how much information is being gleaned so far. So those more specific types of financial insecurity codes replace this one. Social drivers of health, conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. They refer to community level factors and are sometimes called social determinants of health. So this is adapted from the CDC's Healthy People 2030 definition. Separate from that, health-related social needs, social and economic needs that individuals experience that affect their ability to maintain their health and well-being. They put individuals at risk for worse health outcomes and increased healthcare use. So here we're talking about individual level, not community level, but individual level factors such as financial instability, lack of access to healthy food, lack of access to affordable and stable housing, and so forth. So we can see there's a bit of a blend across the Z-code set, but I encourage you to put in your own search for the social drivers of health, cms.gov. And as far as the updates that I just showed you, while we're still dealing with cms.gov, let me also address this briefly on the discussion today. You can always search for Table 6. And Table 6 from CMS is a great way to update yourself without attending any webinars. You can see the first hits are a bit of a ambiguity, but you do finally get to what you're looking for. Fiscal year 2026, IPPS, Inpatient Perspective Payment Systems Final Rule homepage. And when you click there, it can be a bit of a journey through cms.gov's website, but you'll eventually navigate to that which you're looking for with just a little bit of diligence. As you get down here to the final rule tables, you'll see here tables 6A through 6K, or table 6 as it's affectionately known. Table 5 just next door are all the DRGs with their names, relative weights, GMLOS, if that's what you're looking for. But here you can see things like new diagnoses codes, invalid diagnosis codes. That would be good to know, right? If any of the topics that you're reviewing. So we'll take a quick look at those. I've, of course, already downloaded the tables, so I'll just cut over to that and share it with you. And you can see right away new diagnoses codes under the Z59 category that I just showed you on my own spreadsheet. Now, these are not CCs, but they are to do with SDOH, financial insecurity. Okay. If you was any doubt about the elimination here, this particular one is 6C are the codes that no longer apply. So invalid diagnosis codes. Since today's topic is Z55 to Z65, easy enough to go in and see which codes, if any, were affected. Sure enough, this is the code, the more generic financial insecurity code that has become modified with 3 potential entries. And then 6J, if you were interested to know which of the codes are CCs, you can go over to 6J. You can learn all of the Z codes in the 55 to 65 code set that we're interested in today that would count as CCs. You can see there's quite a bit of diversity to the and granularity to the homelessness and housing stability or lack thereof code set. So good to study it, good to think about what type of documentation would tie into these particular codes because there is some subtlety to their definitions. So find table 6, download it, have fun looking through all of these. If you want complete lists of MCCs and CCs, you can, and if you're good at sorting and merging, you can make your own master sheet like this one that gives you some way of navigating. I'm going to keep this one handy as we go through some of the other questions on Z codes today, and we'll see which ones may be of value to us. All right, so just a quick detour through that. Any questions for me from the group? really important that you empower yourself with the knowledge and you don't just rely on a webinar or an update from work. You have to become a scholar of the ICD-10 code set, at least parts of it that are high yield and commonly used portions of the code set, if you're going to succeed in this industry over the long haul. There are so many updates. There's mid-year updates to consider as well, mid-fiscal year and close to the end of the fiscal year as well. So keep an eye on the prize when it comes to these. These are becoming increasingly so important. So the Social Determinant of Health Z-codes capturing non-medical social problems, conditions, or risk factors that affect access to care or adherence to treatment, right? If you don't have access to money reliably, how can you adhere to your treatments? They cost a lot of money oftentimes. And if you don't have a stable place to keep your things safe, how can you prevent your medications from being taken from you? It's a possible outcome that we don't always consider if we have all of these social determinants in place in our own life. So chapter 21 of the guidelines has this factors influencing health status and contact with health services. They revolve around different elements like education, as you see, employment, occupational risk, physical environment, the housing, the Z59, because they do earn CCs, many of them, they became the more heavily focused upon. But you can see they live amongst a number of other important code series. The Z60 for social circumstances like isolation and adapting to living alone, for example. Z62 upbringing related and family support and other psychosocial circumstances. So we really almost do seem to have a code for everything. It's not quite true, but we have codes for almost everything that happens to us as human beings out there. And so the social context really matters here. These are not medical diagnoses, and so we have different documentation rules governing how we can pick them up for coding purposes. And as this last question just pointed out, this very first question that we looked at today, these codes may be assigned together to reflect the patient's full social risk profiling. So there's no hierarchy or excludes one should exclude the other than you should get the right specific code within a given code series. So if it's about housing, you'd want to get the most specific housing and not use redundant or multiple codes that conflict in some way. But in terms of multiple categories, certainly allowed. Another thing to point out to you is that health risk assessments are mentioned in the question that we just looked at. And that's not something that every CDI specialist or coder necessarily gets involved with on a daily basis. The CDC does have clear guidance. This guidance is pretty old, but it's still used for how most departments roll out awareness about health risk assessment. So you should be aware of the elements involved. You can see that there's a number of biometric pieces put into place. A lot of this is self-reported. This is the patient self-reported data in most instances. So if you've ever had any experience with health risk assessments, again, you can pop off to the CDC website and get details where you can get some of the history on it. But very importantly, all questions must be actionable. So you want to have some outcomes linked to the things that you're screening. So if you're asking about weight, what about weight reduction? If you're asking about smoking, what about smoking cessation efforts? The literacy level should be written at the 5th or 6th grade to accommodate the majority of society. We don't want esoteric medical language embedded into a health care risk assessment of any kind. It should be appropriate and it should be updated. The main element that you see here has to do with identifying chronic diseases, injury risks, modifiable risk factors, and urgent health needs. So which types of professionals are likely to be documenting these health risk assessment components, would you guess? And where do you see them in your daily workflow? Sure, good. Case managers. Nursing, certainly. Frontline workers, EMS, for sure, will be very rich sources. Anyone going to the place of injury in a home, for example, or out on the street picking up folks that need urgent medical care. So good, frontline workers. Utilization reviewers may well be aware. How about social workers? Social workers are a very common source of notes that richly describe all of this information. Now, how often do providers pull that information into their assessments and plans, by your experience? Yeah, not very often. If they're not willing to pull through those key comorbidities from the consultant's notes when it comes to medical diagnoses, unfortunately, the providers are even less likely to pull through social determinants that they may feel don't have much to do with their direct medical care. And yet, if we could give those providers insight into something simple like readmission risk, and noting how important having some of these social determinants of health memorialized in their notes, as well as others' notes on the treatment team, we'd be a lot better off when it came to readmission risk and the readmission index, which frequently can be disproportionately high. So we need to really try to educate providers. It's not just about some of them counting as CCs. Even the non-CC, non-MCC Z-codes that relate to SDOH have such a rich impact on length of stay, as mentioned, readmission risk. In some cases, even risk of mortality can be an expected risk-adjusted expected mortality can be tied back. So it becomes interesting. The guidance, of course, is to have these questions amongst all these other assessments. So whomever's notes you may be privy to get this information, expect to see the information for the Z-codes, Z55 through 65 series, buried amongst these biometric assessments. There should be the psychosocial risks that begin to talk about some of the drivers behind things like isolation or stress or depression. Behavioral risks and home safety in particular is an important area to consider here for today's topic. So then there are some other guidelines you can read through here on how to deliver, what the rules are around delivery. It's really a deeper dive that most of you will need to take, probably, but it's good to be thorough when you study a subject. Try to learn all of the key legislative points around it and how it's actually enacted and who the players are. So let's continue on with this visiting of the topics at hand, social determinants of health, with this next question. Take a minute to read it. I will monitor the text box and also hope to hear somebody confidently jump on and tell us all about number 2. Great. I'm seeing some quick and accurate initial responses via chat. Thank you, Erica. Thank you, Medina. B is correct in this case. So you read quickly and accurately. Here we see a nurse who documents transportation barriers during intake, and that intake note is considered at that facility part of the legal medical record. The attending does not restate this transportation barrier that the patient faces, perhaps making it back and forth to appointments and not being able to secure transportation, not showing up in the attending's documentation, but it is in those nursing notes. So how do we handle that? How many on the call, I wonder, were thinking, well, it has to be pulled through just like malnutrition from the registered dietitian note or something like that. In fact, these we can take and code based on any licensed professional who is documenting these types of circumstances. So certainly a nurse who's part of the clinical team and whose documentation is considered part of the official medical record is considered a reasonable source of any Z-code that pertains to the topics at hand today, including transportation barriers. So we would not limit this to outpatient settings. In fact, there was a disappointment in that the Z-codes are no longer part of the quality measures, these particular ones, 55 through 65, for social determinants of health, no longer considered for quality measures on the outpatient side. Was kind of a jaw-dropping announcement, frankly, for a lot of people in the industry. But for inpatient, we see that we still love our Z codes, 55 through 65, for these circumstances. So we definitely wouldn't think about choice D, the outpatient setting, which is no longer seemingly interested in this topic, administratively anyway. Do not assign unless social work also documents it. Okay, maybe a social worker is more likely than a nurse to inquire about transportation. We don't know that for a fact. In this case, a nurse was the one who was aware of the subject, but there's no mandate for it to specifically be a social worker as the licensed professional giving this information. And A is the misconception that the provider who's admitted the patient or who is discharging the patient must verbatim restate the barrier. In fact, we prefer when clinicians do restate those types of status issues in their own words rather than verbatim copy, as long as they don't conflict. So, would you ever query a physician about a Z code? Sure, you would. If there's a conflicting documentation, as just mentioned, you may still have a reason to query. So be careful about how questions, if you were preparing for CCDS or CDIP, make sure you read the stem of the question. If it states that Z codes were provided by a nurse, a social worker, a case manager, but that also the provider had contributed something and it seemed to be at odds with what was being stated, like non-compliance of medication was due to dissatisfaction with all of the side effects, metallic taste in the mouth, left them feeling lightheaded, but the social work team or somebody else on the team is writing they didn't take the medicine because they can't afford the refills. So they took the free samples and they never filled the 30-day supply at the pharmacy. At that point, it doesn't matter who's documenting. There's a conflict at hand that needs to be resolved. And who would you query in that case? You would still query very good the attending or the responsible admitting / discharging provider team, because in the end we need their definitive commentary on. They are the final say on any sort of conflicting documentation. All right, so very good. A good work on number 2. Let's consider some other factors here. So it's section 1B14 of the guidelines that points out that sure, the default is that the provider should be the one from whom we code, and very specifically, we want the provider's assessment and plan documentation, not the problem list, not the subjective narrative, but the assessment and plan. But we make exceptions for certain parameters from other clinicians' documentation where we do allow coding, and the Z55 to 65 codes are included, along with things like taking BMI codes out of RD documentation, registered dietitian documentation, ulcer staging. The staging can be taken from wound care nursing notes, certainly better qualified than most providers to tell you the exact stage if they're in there and caring for that wound every single day. And particularly important to get that post-debridement staging accurate. Coma and stroke scales, you know that there's a list of some other select non-diagnostic items, so you can navigate to that part of the guidelines to remind yourselves of where this exception fits in, among others, for picking up codes from non-providers, quote unquote, these are all providers in a sense. They're very talented professionals with licenses and hours of training and supervision. So it's just a matter of what we can actually take. These are non-diagnostic. Being homeless is not a diagnosis. And clarifying if that homelessness is in a shelter or not in a shelter. You don't need to be a physician to clarify that information, nor do you need to be a physician necessarily to weigh a patient and get their, measure their height as well as their weight and get a BMI calculation. So this is the reason you can rationalize some of the coding rules, the way that they roll out. Okay, remember though that the documentation must be part of the legal medical record. So if somebody throws you a curveball on a test question, well, the social worker notes mention it, but they're not technically part of the legal medical record. They're just testing if you know that concept. It's not realistic. The notes are always going to be part of the legal medical record, except for very unusual circumstances. And again, we've already mentioned that the conflict should always be resolved by the provider, the admitting team. All right, let's look at another question. Okay, so a patient completes a health risk assessment and indicates frequent meal skipping. The assessment sits unsigned in the EHR. There's no clinician note that references it either. So what is the most compliant action before coding? We have a couple of codes we could assign between A and C. We could ignore the results and do nothing coding-wise, or we could query. I'm seeing choice B is popular in the chat box. Very good. Good point to make here. Thank you. It's tricky because we don't know if they are skipping intentionally, like an intermittent fasting situation, or if they are skipping because of circumstances forcing them to skip meals, perhaps socioeconomic circumstances. That's a good thought. If we take a look at the choices, it seems like it would be more to do with the inability to access food. But I agree, the question could be a bit more specific to accommodate for that by saying unintentional, frequent unintentional meal skipping. So is that language enough, and does it matter or not matter? Does it matter or not matter that the clinician has co-signed this assessment or referenced it somewhere? In this case, it matters, right? Because why? This is not a nurse reporting this. This is not a social worker. This is not a case manager. Who is this? This is the patient themselves, and this is a self-report. The patient's completing the self-report component and mentioning that they frequently miss and skip meals. So we don't really know what that means, right? We don't really know if it's food insecurity, 5941, or is it other specified lack of adequate food? What do we mean by other specified lack of adequate food? It means that the food insecurity itself tends to be more general. In general, there's not enough food. It's an ongoing problem that we are constantly looking for food. It's an overall insecurity in our household or for the person, the individual. Other specified can mean, well, on certain days of the week, we have a hard time getting access to food for various reasons, like transportation could be mixed in there, or certain days of the week, we only get this kind of food, typically less than ideal food. So there's some calories going in, but they're not ideal in nature, perhaps access only to snacks that you would find in a vending machine rather than things with good nutritional value. So you can see there's some subtlety to the code set, but we wouldn't know much, would we, from frequent meal skipping? So absolutely, those who chose B would be correct here. Query the providers to sign off, first of all, and incorporate that health risk assessment info in their ongoing assessment. After all, if this patient has nowhere to go that's for stable housing and has a hard time securing food, the chances of them following up with their medications and their health appointments is quite low. And if that's not incorporated into the discharge summary and into discharge planning, we're going to have a hard time justifying that less than 30-day readmission with no explanation other than here they are back in the hospital. Does that become a quality of care measure that's impacted for the hospital? Gee, your patient sure did come back fast. Well, yeah, they barely recovered from pneumonia. We sent them out with oral antibiotics for which they never filled the prescription, and then they were sleeping in the cold, and they had other circumstances going on that prevented them adequate nutrition for full healing and full immune system function. So of course they're back, right? We need that information there. And so most of the time, the notion of a sign off may not be something that's familiar to you, but electronic health records certainly can build in templated components with drop down menus and with smart phrases to help providers incorporate some of these facts into the notes that they write by feeding in the information from case management, social work, and so forth, other nursing notes. So there is a way to even track that that's very valuable. So very good. So we can code. Patient self-reported is not the same as a nurse, case manager, social worker. We can code only when the clinician or the provider signs off and explicitly incorporates that report into the medical record. So that typical screening that's done at intake should really be picked up as a provider attestation right away, day one or day two of the admission. Something like I reviewed and incorporated the findings noted by social work or case management or utilization on such and such dates, and have it in there formally. If they're unsigned patient input output type of statements or the standalone paper forms that get amended and scanned into the record, any of that self-reported is not going to work without the sign off from the provider. And so by getting these embedded attestations right into the EHR for quick click and endorsement by providers, you really reduce the burden of post-discharge queries. That's why CDI exists, is to help reduce that burden for inpatient coding to get the fiscal and quality piece right. CDI is meant to do it concurrently. This is an easy way. The circumstances will be known right at the time of admission. Easy way for CDI to help here. Let's have a look at another question, please. This could be considered a good one. I would agree with you. It makes you think a little bit harder. Thank you for the comment in the chat. 45-year-old man with pneumonia comes into the hospital, social work and nursing let us know sleeping in a car, no shelter intake forms completed to date. Hygiene resources are limited to public restrooms only. So which code is most appropriate? seems like we have some details, right? So choice A, homelessness unspecified. I'm not sure I would pick it right away as a choice. Housing instability unspecified. There seems to be some specific details that there is no housing available, leading to sleeping in the car. Yes, and some important comment added in here. Thank you, Kaylee. I don't know if a car counts as shelter. That would be the natural thought for anybody, right? Are we going to call sleeping in a car that's shelter from the storm, isn't it? If it starts raining, and presumably the car is in reasonable shape and can keep out the elements, then you might think of it as shelter. But in fact, it's not considered shelter. It's not an official location that human beings are meant to dwell in over a long period of time and think of as a home. Perhaps if you didn't have car in the question, we know that some people take to the road and live very stylishly in large vehicles they've converted from school buses and from other creative ways of living. We're not talking about that type of living. We're talking about literally a car because there is no home, so that the car becomes the only choice for a place to take refuge in the evenings. So plus that currently sleeping, maybe he's away from his home, right? So we would need more details, right? We would need to know, are you always living in your car? Is this temporary because some plans fell through and you're away from your home base? For sure, you'd want to know all of those details. In this instance, though, sleeping in a car certainly makes us think about unsheltered homelessness. So let's take a look. There's quite a bit of granularity to the topic of homelessness, and you can see that exactly the good point made just now. The we have the documentation should describe current living situation and some historical piece as well. So if it's known, as it says at the second sentence, additional housing instability subcategories can help us to complement that homelessness status so we know the risk trajectory across recent months and also predict them for the future. If the answer is, well, things fell through on this and that, but in 2 months from now, circumstances are improving dramatically with housing and access to food and so forth, then that's a different trajectory and a different risk that you would be monitoring. So you can see here, when you get into the code set, and again, all of these are CCs, the ones listed on the table here in terms of diagnoses, but you also want to look very carefully at the circumstances. As correctly stated about the parenthetical notes, 59.02, this is for residing in a place not meant for human habitation, not long term anyway. So abandoned buildings, cars are specifically named in the unsheltered category of homelessness, living in a park or residing on a street or on a sidewalk in a tent or something like that. That's still not considered sheltered, even if you have something physically over your head to shelter you from the elements. So it's a little bit of a subtlety. And you can see as you go through, there's a little bit of studying to be done from the CDI team. You'd want to read all of the deep coding guidelines around these codes to really know what you should be seeing in that provider documentation. For example, there's inadequate housing utilities, other inadequate housing. It starts to all sort of inadequate housing unspecified. So, for example, other inadequate housing, if you look at what it refers to, pest infestation, that's what's made the housing inadequate. You can't live there because it's infested, or poor weatherization. There's no insulation, so you would freeze overnight because of the wind, the cold wind blowing through, or with the desert communities, no insulation from the intense heat, no proper cooling system, restriction of space, technical defects. You can see very specific things accounted for, unsatisfactory surroundings, like a hoarding situation where one member of the home has rendered the house unlivable. All of those things can be teased out, and the codes are quite specific for that. So it doesn't matter that they're all CCs. You want to get the right one because they all tie back into the potentially the risk adjustment side or having the most complete medical record that's possible, which is what we're always meant to be doing, is getting the right circumstances down for that continuity of care. Okay, if a patient doesn't have a place to live and they don't have good transportation, how will they make it 3 times a week to hemodialysis? Don't be surprised they're back with hyperkalemia 10 days after discharge. In fact, since 2020, we've been studying these Z-codes, and this table reminded me of that from an older source that I had referenced in an earlier lecture, addressing common barriers to the use of Z-codes. So we've had all sorts of national level projects. Let's define the social determinants in a more granular way. You can see fiscal year 2026, we're getting there with very granular definitions. There are still lacks of incentive. You can see that many of the incentives really are not there for the other circumstances. It's mainly around housing right now when it comes to a fiscal incentive anywhere. Anyway, and in operational processes, we should be constantly screening our own way of picking up these Z codes and seeing if there's really a better tool that can be used. Many facilities have outdated processes and outdated tools, and they could be subject to some upgrades. So you can read about a lot of this in the American Hospital Association's publications around SDOH codes. I'm going to move on in the interest of time and just look at a few more questions to wrap up, but I'd love to take your thoughts on any of this at the end as well. Which phrasing here most directly would support assigning Z5941, if I can see by way of text box or microphone? Which of these statements would prompt that code? Okay, good. Everyone's very confident on B. Diet may be suboptimal. Yeah, lots of people's diets are suboptimal. It doesn't mean that they're dealing with a food insecurity. BMI could be low for the age for a number of reasons unrelated to food, such as a developmental delay or a nutritional deficit or a difficulty with absorbing nutrients, for example. Patient dislikes hospital food is clearly the outlier choice that you would eliminate right away. Doesn't make any sense. Okay, very good. So most everyone jumped on those. Great job. Choice B. Food access. So food insecurity, as mentioned earlier, generalized ongoing concerns about access and availability of food versus other specified 5948. Maybe the food access is inadequate sporadically, or there may just be some food types that are limited. Either way, the clinician should be documenting all of this because does it matter? Of course it does. Food access, how can you adhere to your medications? Many of them need to be taken with food to prevent terrible nausea and even vomiting in some cases if you don't buffer that medicine with food. Glycemic control, wound healing, the ability to take in enough protein to heal from a surgery, for example, and being ready for discharge. All of this can prolong the length of stay for sure. So getting templates in place is very helpful for providers because they don't always know what to write that will translate to being codable. Let's see if we have time for a few more here. Which code combinations best reflect SDOH coding beyond the Z59 family that we've been looking at when documentation ties the environment to care impact? So are any of these environmental to your eyes? Can you rule any of them out to help you get to the answer? Which Z-codes speak to environment? We're going to take a sneak peek here. It's 58 and 60. So if we just cut back to our table, 58, we can see inadequate drinking water supply, basic services unavailable, other problems related to physical. 60 on the other side of the 59 codes, problem of adjustments to life cycle transitions, problems related to living alone, acculturation difficulties, social exclusion and rejection, target of perceived adverse discrimination and persecution. So you can see the details are quite specific, and in some cases they may tie into other codes. Some of them may be psychosocial in nature. Remember that homelessness, there is a higher percentage of the population dealing with various mental illness than those who are in amongst the housed community. So we have to consider that as a causative factor and wonder if there are any codes missing. It's not always the case, obviously. People fall into these categories for many different reasons, the least of which is mental illness, but there is an association with homelessness to be considered. All right, so what about the other codes that were there? Z51 aftercare codes, Z13 screening codes, Z68 for the BMIs, Z00, those are a general medical exam with or without abnormal results, Z79 for long-term drug therapies, and Z99 for machine dependence. So clearly none of those has to do with the environment. Okay, let's see. Let's jump into one more. We've pretty much talked about that. Final question for the what time we have today. Which of these KPIs most directly measures whether positive social determinant of health screens become codable entries? So the most direct measurement of whether we're coding SDOH. Screening completion rate, not likely, because that's the patient's job to complete that, and it's nothing to do with what we measure or do with that information. Average length of stay, not too sure. Perhaps. Readmission rate, perhaps. These indirectly probably measure, but the choice B that we see here is much more accurate for whether we're actually going to code. So remember, while most of this nursing and social work type entries can be taken, the screening is patient self-report. So for patient self-report to make it to coding, we need the clinician to sign off, so that we're looking for that median time to sign off when we use those feed-forward EHR alerts to get the provider's input. That's only because it says directly measures in the question. Of course, readmission rate and GMLOS or any other length of stay would be considered to be an indirect measure. So just tying this up before we wrap it up for the day, because we are almost at time, make sure to combine discrete checkboxes into those provider note templates that use the narrative fields. You can include those codable phrases and also mention to the provider in a side note what their clinical relevance would be. Make sure that those all get routed with templated language that the provider can modify, but ideal should have some sort of reviewed and incorporated statement. You may want to use smart phrases to make it easier for the provider. For example, if there's an oncology service that routinely deals with patients who miss their appointments due to transportation, simply typing in the word transport could trigger a phrase that then allows the provider to get that on the record with a minimal effort in terms of typing. We want to make sure that when self-reported SDOH items from the patient are not co-signed, we want to make sure that that has a triggered through to CDI, so that CDI is prompted to go ahead and query for that, because that will need a query if there's no cosign and there's no other comment from any other clinician. You also want to track the sign-off rate. That's what that last question was about. The best KPI will be that sign-off rate. And also a good general measure would be, what is the SDOH code per 100 encounters broken down by the Z-code category of interest, and perhaps stratified by service line. What you want to do then is be responsive to your hospital's actual problems. So you don't need to track every provider every month, but if you find out a handful of providers are contributing to a deficit in Z-codes, then get those on your KPIs for your monthly dashboards and start tracking exactly where the provider accountability might lie if you see certain service lines are not picking up these codes at all. And make sure that you refer the patients. This is the social piece that has to be worked out with discharge planning to try and correct. There should be an effort made by the health system to try and correct this difficulty with access to food, housing, transportation, and other key modifiers of health. All right, so that's the end of the discussion for today. The date must be for the current encounter. Yeah, we need to make sure we clarify the dates correct and make sure that the circumstances are current for the dates of the admission at hand. Absolutely. Good point. Thank you so much for your kind comments, everybody in the chat. Are there other questions I might answer from any of you? Thank you for participating and attending. Okay, just to give a quick shout out again then. All of our programs are listed on our website. We have apprenticeship programs, certification exam, preparation programs starting scheduled out through January already. We have professional coaching at every level of leadership and staff in CDI. And this will be next month's Tuesday, December 16th, Enhancing CDI Outcomes, a CDI department case study. Looking forward to sharing with you all of the interventions that we get involved with when we optimize CDI operations at a facility. So if there's nothing else, we'll say goodbye for today and look forward to seeing you all next month. And again, thank you for attending.
Thank you, everybody. We'll see you next month. Happy Thanksgiving to you and your families. We very much appreciate you all.
Take care, everyone. Goodbye.